Welcome. My name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. Welcome to our webinar series. Today's event is entitled Birth Doulas Addressing Systemic Racism in Underserved Communities. Today we have Amy Chen, a senior attorney for the Doula Medicaid project at the National Health Law Program. We're also joined by Grace Guenther, a research scientist at the University of Washington's Center for Health Workforce Studies, and Paula Kett, also a research scientist at the University of Washington's Center for Health Workforce Studies. Now, with that said, I'm going to go ahead and step back and let our presenters take over the show.
Hi, everyone. So my name is Grace Guenther, and together with my colleague Paula Kett, we will be presenting on our work on the experiences of birth doulas and those who work in underserved communities. And our guest, Amy Chen, will be presenting on the practical implications of this kind of research on expanding access to doula services through state Medicaid programs. I'd first like to take a second to acknowledge our study team at the University of Washington Center for Health Workforce Studies and our funder, HRSA, for sponsoring this work. So to begin, a birth doula is a non-medical trained professional who provides physical, emotional, and informational support to a pregnant or birthing person during the perinatal period. Doulas can provide a wide range of support to clients during these life transitions, but for the purpose of this presentation, we'll be focusing on the role of birth doulas. For some background, pregnant individuals of color, particularly Black and Indigenous people, experience significant disparities in birth outcomes, with maternal mortality rates often 2 to 3 times higher in these populations than in white populations. Research has found that the stress associated with exposure to racism is a major underlying factor, including higher rates of preterm births and low birth weight, depression, and PTSD, as well as lower odds of breastfeeding. Patients of color have reported greater incidences of delayed care, gaps in communication with providers, shorter encounters with their providers, and extended wait times for appointments compared to white patients. Community-based birth doulas and their services can positively impact birth outcomes, especially those of underserved populations. They do this by helping to decrease maternal stress, lowering rates of C-sections, and increasing satisfaction with the birth experience. So having access to doulas who understand and have experienced the effects of systemic racism increases the patient's trust and engagement in care and strengthens their agency and decision-making processes. So as doulas have contributed to these improved birth outcomes, researchers and policymakers have pressed to expand access to their services. However, there are some challenges with this. The current system struggles to provide the needed training, compensation, and support for doulas working in underserved communities. And doula training has been historically grounded in the experience of white upper-class women and rarely includes topics specific to the needs of underserved communities. There's also a lack of understanding of the working conditions of community-based doulas and what is further needed to support their work and develop equitable policy. This is particularly important considering the COVID-19 pandemic, where research has found that many birth doulas experience barriers to providing their services through being deemed non-essential personnel and not being allowed in delivery rooms during the pandemic. So the aims of the study, we aim to address these issues through a two-pronged study. First, we examine the various approaches doula organizations have taken and their perspectives on what system-level changes are needed. And in our second study, we focused on the work of individual doulas, their work experience, stressors, and motivations, and working in underserved and historically excluded communities in the U.S. In addition to literature and policy reviews for both studies, we recruited participants through web searches and snowball sampling. 16 organizations were interviewed in our first study. These organizations trained or certified birth doulas, employed doulas across a variety of work environments, and/or were involved in research, policy, and advocacy for doulas. We asked these organizations how they recruit doulas into training or employment, skills and competencies they trained for or required from their doulas in working with underserved communities, and the barriers and challenges their organizations faced in the scheme of the larger doula workforce. And for our second study, we interviewed 18 individual doulas, many identifying as a person of color, and they worked across a variety of health settings and employment situations. Interview questions focused on their background as a doula, their motivations for becoming a doula, payment for their services, the communities they serve and how they address their community's needs, the challenges they face in the work and the strategies they use to address these challenges. We then conducted a thematic analysis using key themes brought forth from these interviews, and then we kept in touch with our interviewees, sharing our results after they were published. And then now I'll turn it over to Paula to speak more on the results.
Great, thank you so much. I'm going to talk a little bit first about our results of our first AIM, where we spoke with the training and employment doula organizations, and we split these organizations really into two major groups: mainstream organizations, which were focused more on the national level training and certifying organizations, as well as hospital-based employers, and then community-based organizations, which tend to be more locally rooted, and their training is more specifically focused on the communities that they are a part of. And so kind of this first, oops, there we go. So we found differences between these organizations with regard to how they approach training, and then also how they approach recruitment. So for training, we found that mainstream organizations tend to be more clinically based, really focused on, how the stages of labor and physiology of pregnancy and birth, and then how doulas, support that, both physically, can support that emotionally and informationally. Community-based organizations include this information, but also included additional topics that were really specific to the needs in their community. That both types of organizations discuss the importance of including content that specifically addressed the way structural racism impacts pregnancy outcomes. The difference is that community-based organizations tended to have already had this incorporated and had been doing this for a long time, are really experts in incorporating this into the content and training. And mainstream organizations, this was newer for them, and they were just starting down the road of incorporating this. And then for recruitment, mainstream organizations tend to focus, think about client needs, but also think a lot about how well the doula matches the healthcare team when they're recruiting. And community-based organizations focused more on recruiting doulas with lived experiences in the communities that they were serving. So there's just a slightly different perspective. Both organizations really struggled financially to secure sustainable sources of funding. This is a very common theme and will come up again when we talk about our findings with individual community-based doulas. So they also talked a lot about proposed systems level changes. We focus here specifically on the expertise from community-based organizations because they've been in this work for a long time, and their perspective on what systems level changes are needed are really relevant here. So first, they emphasize the need to acknowledge racism as the cause of pregnancy-related health inequities. And we really highlight this here because they said, right now there's this big focus on doulas as the answer to perinatal inequities. And doulas are a big part of the answer. But as community-based organizations, CBOs, said, if we aren't also addressing racism within the structures, then we aren't going to make any headway in outcomes, as this quote gets at here. We have to address institutional and systemic racism, or we are not going to continue to get the birth outcomes we are getting, or we are going to continue to get the birth outcomes we are getting, because the risk factor is racism, and I think not enough people are paying attention to that. Second, they highlighted the need to shift the balance of power across organizations. First is two things. First, to empower CBOs in giving the training and employment and that they are right now doing, and really allowing them to serve their communities in that way. And then second was to increase representation of doulas and community-based organizations in policymaking and decision-making processes. And then finally, it was important to consider the trade-offs of policy approaches to expand and improve access to doula services. And this really came because CBOs highlighted that the concern is that policy change like Medicaid, Medicaid reimbursement has a lot of potential benefits, but that the trade-off is it can affect create a scope of practice that would not align with the needs of doulas and would push expansion of doulas deeper into hospital hierarchy. And this quote kind of gets at some of that concern. Once public money is going into something, it perpetuates systemic racism. And the people working in the communities experiencing the highest levels of maternal mortality get locked out. A fear among those who do community-based work is that when the system steps in and creates structures, that the system already has structured racism and classism. So moving on to experiences of individual doulas, this came from our interviews with doulas around the community-based doulas around the country, and they really shared also impacts to their work experiences that really the need for systemic changes as well, similar to what CBOs discussed. And they shared the stressors that they experience also in their work that are really because of these systemic inequities and the ways they try to mitigate the effects of stress. So first, they shared ways that they are really doing specific work to advance perinatal equity in the communities that they serve. This includes this fostering a deep connection. They share this need, the ways that they do this through being a stable presence with their clients before, during, and after birth, and really being able to understand clients' social and health history, fears and anxieties, and preferences for care. As this quote gets at here, when you work with people and have a connection with them, you know what their personality is, you know if they have high anxiety or if they don't like to be touched or whatever these things are, you're in a more valuable position to be able to support people. They also emphasized facilitating culturally specific birth practices, saying that for many clients, reconnecting with the ways that pregnancy and birth had historically been supported was a healing process, as this quote gets at. As a people, we have a lot of taboos that we would abide by before, during, and after pregnancy. We have ceremonies that we do. We are limited to certain interactions during that time, certain foods and activities. In our community, pregnancy and birth is really sacred. And so there are protocols that we as doulas and the families typically uphold as we're providing our services. Third, they empower clients to really advocate for themselves, to learn to listen to their own intuition and their bodies, to be able to identify what they want and clearly communicate that. And said that this is a really important in particular among birthing people of color who often experience being unseen and ignored in perinatal spaces. As this says here, there's often a huge issue with Black birthing people and other birthing people of color. We can go unseen and unheard in that space. It's making sure they're armed with the language to remind the providers, I do know some things. And then finally, they shared ways they address additional, more upstream needs, such as helping address food insecurity or other connections to other social services, housing, etc. They did share numerous instances of both witnessing and experiencing discrimination in supporting their clients. With witnessing discrimination, they shared instances of clients being ignored, pressured into certain interventions. They shared that there were concerns with how clients were communicated with not receiving full informed consent, and that messaging tended to be more fear-oriented, as this quote gets at. You get to delivery, and it's like there's a lot of expectations of failure coming from the medical providers, people that talk about higher maternal and infant death rates. The frequency that something bad will happen is really exaggerated in a lot of cases to scare patients into being compliant. There's a lot of focus on patient compliance and not as much on informed consent. And then they also shared their own experiences of discrimination, somewhat with being involved with interactions within the hospital environment and hospital hierarchy, particularly when helping their clients navigate the health system. And with regard to discrimination, this doula shared here that it's almost something that I can expect to be met with. It's the way that I'm treated versus how people who are more white passing or white doulas are treated. They, similar to the organizations, shared about the struggle to stay financially afloat. They shared that it's complicated to maintain a livable wage a majority of the time. They affirmed a desire to be fairly compensated, but also shared this concern that raising rates would then increase barriers in accessing their services. So they're living in this tension all the time. As this quote gets at here, do I think I should be paid a lot more for my work? Yes, absolutely. However, the women who need me can't afford to pay me what I really should be paid. So do I just leave them, or do I take the time to help them? Many interviewees held this perspective that everyone should have access to these services, that these services should be considered essential. However, they also shared frustration that they often felt that there was this expectation to provide free services due to who they serve, and that they were frustrated with being asked to provide pro bono services, as it tends to reinforce privilege and racism that is in the health system. As this quote says, I'm not going to ever ask a Black woman to work for free. Our ancestors already did it, and I already did it. They shared that there are a lot of stressors that they experience in this job. And so there are ways that they have, strategies they've instigated to mitigate these effects. Peer support, really supporting each other, providing care for each other. They often called it being doulas for doulas, to minimize burnout and support well-being. Reconnecting with their motivation for the work, their motivation to really help create a different experience, one that people they serve are more informed of their choices, and that they feel good about the options that they have, and however it turns out. And this is really getting at that, just seeing the impact. Somebody had a birth and it didn't go exactly how they wanted, but they aren't traumatized by it because they had this person that was there unconditionally, without judgment or their own agenda, supporting them through. They also said, often with this emphasis on doulas, they find themselves feeling a lot of pressure, and that it's important to remind themselves that their job is not to take on the full responsibility of fixing broken systems, that they are doing their part in serving their communities. So overall, findings really affirm current research about the positive role of doulas and the services they provide, which address perinatal inequities and improve outcomes. These findings really show that the skills and the expertise of doulas described are an essential part of interrupting negative pathways between social determinants of health and birth outcomes. We see that doulas are engaged in and committed to equity work amid strenuous work conditions and without systematic financial and political support. And we see that the results here really point to a systemic deficit in the perinatal health system, and that this deficit places additional burden on doulas to address that. We also really wanted to elevate the expertise and experience of community-based organizations and show that they are well positioned to engage in the systems change work which is needed to increase doula support and access to doula services. Findings also indicate the complexities of policies such as Medicaid reimbursement, showing that it can increase access to doula services, but can come with its own trade-offs. So thinking through next steps, community-based organizations really need to be placed at the center of decision and policymaking processes, which focus on expanding support for doulas and access to services. And doulas, individual community-based doulas do as well. In considering compensation, it needs to consider the complexities of the doula's work, as well as a wide array of services that they provide. Systems level changes are needed to address root causes such as racism and to create a foundation which advances equity in perinatal health outcomes. And then finally, future research is needed to further examine both competencies and skills among community-based doulas, as well as what supports are needed to sustain and address the well-being of this workforce. One of many future research areas that's needed. So that's all for my part. I'm going to pass this off to Amy now to share a little bit from the state perspective.
Great. Thanks so much to both Grace and Paula. And I just want to say that, you know, I myself, I'm so grateful for the work of just really intentional researchers like Paula and Grace, who have really been foregrounding equity in their work and also embedding in their research just a real understanding of the devastating impacts of systemic racism and sort of what that looks like. So just want to express appreciation for the two of you and all that you do. So my name is Amy Chen. My pronouns are she, her. I work with the National Health Law Program. I'm going to be talking a little bit today, just kind of doing a very quick overview, sort of where states are in implementation of Medicaid coverage for doula care, and then also looking at some challenges and best practices. And I think all of this, follows very closely and sort of hews to what Paula presented in the research. So. Just a little bit quickly about the National Health Law Program. So we're a national nonprofit law firm working to protect health rights for all and improve health access, equity, and quality, especially for low-income and underserved individuals and families. We have offices in California, where I'm based, and also North Carolina and Washington, D.C. And in our work, we work really closely, and primarily, I would say, with legal aid attorneys and health advocates across the 50 states and in Washington, D.C. So I myself am part of NHELP's reproductive and sexual health team. So my focus has traditionally been on pregnancy coverage and maternal health. I also have been leading NHELP's work around Medicaid coverage for doula care. So our Doula Medicaid project, which was launched in 2019, is working to help improve health outcomes for Medicaid enrollees by supporting doulas and advocates across the country and expanding access to doula care for pregnant and postpartum people enrolled in Medicaid. I did want to note that at NHELP, we're lawyers and researchers and policy advocates. We're not doulas. So as such, we seek to do all our work in partnership with and with the guidance of community doula groups, doula collectives, and individual doulas, especially doulas representing groups most impacted by disparities in care, including racial disparities, and including Black doulas and Black-led doula groups, as well as doulas and doula groups serving low-income clients. I did want to mention that we maintain a national doula Medicaid listserv, so sort of sharing information and research around doula Medicaid. If you'd like me to add you to the listserv, you can send me an email. I'll be sharing my email at the very end of the presentation. So as I mentioned, the Doula Medicaid project, we started, tracking, we launched in 2019 and started tracking kind of national state efforts in that year. There's been a clear increase of bills every year since 2020, 2021, 2022. Let me just see. And so you'll see here, this is just a map of the United States, and it might be a little bit small on your screen, so I apologize for that, but this is also on our website. So I will share, I can share out after the presentation just a link to where you can sort of find a bigger version of this. But basically, if you look at the map, the states in red are states that are actively providing coverage right now. The states that have a little star in yellow are states that are in the process of implementation. And then the states in blue with the blue star are states that have some related or adjacent action to Medicaid coverage for doula care. And I want to say that so much of the research that Paula shared is 100% consistent with what I've been hearing in my conversations with doulas and advocates across the country, because in addition to tracking state bills, legislation, and other efforts, we also, the Doula Medicaid project, we also provide support and technical assistance to doulas and advocates across the country who are working on implementing Medicaid coverage for doula care and expanding access to doula care. So just really quickly, just kind of going over like those stars. Oh, Paula, you can keep it on the previous slide. Yeah, thanks. So there's 9 states and Washington, D.C. that are currently providing coverage. Those are, again, the ones that are in red. There's 6 states that are currently at various levels of implementing coverage. So for example, here in California, where I am, our benefits are set to begin on January 1st, 2023. So just in a couple of weeks. And then another 13 states are taking some adjacent actions, such as legislation related to ultimately implementing Medicaid coverage for doula care. In some cases, maybe convening doula advisory boards or stakeholder work groups and the like. And I did want to say, in terms of sort of where the states are, it is super exciting because, all told, it is over half of all states that are doing something around Medicaid coverage for doula care. Again, either actively providing coverage at various states of implementing coverage or taking some adjacent action. So I think that is super exciting. And I'll share, a lot of the information that I'm sharing today. Some of it is summarized in a recent publication that we have, which again is the one that includes this map that I'll be sharing. So I wouldn't worry about, taking notes or anything like that. So just briefly about kind of some of the challenges that we've seen. So in our tracking of the state legislation, and then also in my conversations with doulas, I think there are a handful of states that I would particularly like to highlight. So certainly Minnesota and Oregon are worth taking a closer look at. Both states have had Medicaid coverage for doula care for some time, but there have definitely been challenges with implementation in both states that I think have a bearing on sort of considerations of sort of workforce and also kind of expanding access to care. A little bit of this there was a series of articles published last year in the Washington Post that kind of detailed sort of some of the challenges in both of those states. And I will say there has been in both states, there has been a pretty low uptake. So for example, in Oregon, the sort of claims data recording from these articles that were published in 2021 showed that only an estimated 200 Medicaid births had been attended by a doula, and this was since the benefit began in between 2015 to 2020. Meanwhile, the actual number of Medicaid enrollees in the state who give birth each year while enrolled in Medicaid is close to 19,000. So definitely, that 200 number is a little bit, I would say it probably is a little bit short. It probably doesn't include some figures for managed care programs and other numbers like that. But definitely it is quite low in terms of the total number of people who are giving birth in the state each year. Similarly, Minnesota, that kind of number was about 850 births, so higher than 200, but still very low in a state that has about 26,000 people a year giving birth while enrolled in Medicaid. A number of reasons for those challenges. A lot of it had to do with low reimbursement rate. In Minnesota, the original reimbursement rate was $411. It was later raised to $770. In Oregon, the original reimbursement rate was $75. I'm not missing a zero. It was $75. It was later raised to $350. And then just recently, earlier this year, after years and years of advocacy, it was actually raised, the fee-for-service reimbursement rate was raised to $1,500. So super exciting. And, hopefully, I think in that state, it remains to be seen. Hopefully with that increased reimbursement rate, that uptake will also increase. And that was certainly the hope of doulas and other advocates in the state. Rhode Island is also super interesting. Rhode Island last year passed a bill, the first in the country to pass a bill that was requiring doula care in both Medicaid and private insurance. And I will say, just in terms of kind of as we're thinking about sort of racism and equity issues, I've spoke with doulas in Rhode Island. They've said sort of unequivocally the reason why they really pushed for doula coverage in both Medicaid and private insurance is because they know that Black pregnant and birthing people have very high rates of maternal mortality and morbidity, and that is the case regardless of socioeconomic status, regardless of income, regardless of education. And so their goal, is really, if we want to reduce the rates of maternal mortality and morbidity among Black birthing and pregnant people in Rhode Island, this cannot be something that is only rolling out in the Medicaid context. So super excited to see that Rhode Island, the benefit began on July 1st, 2022. And before the end of the month, doulas were already reporting successfully receiving payment. So Rhode Island is definitely another state to look at. And then I guess lastly on this point and sort of challenges, as I've mentioned a lot about kind of the importance of reimbursement and sustainable and thriving wage. So do want to encourage people there's a really great report that came out from Ancient Song Doula Services, Village Birth International, and Every Mother Counts. It's called the Advancing Birth Justice Report. Again, I can share this as an additional resource. Let me see. I think we're coming close to time. So, I would say for recommendations that the number one thing is I would really encourage states to try to get this right from the beginning, so you don't have to do a lot of cleanup on the back end. As I mentioned, both Minnesota and Oregon, they've had to pass numerous bills over the years to fix or improve upon their original legislation, including changes to the billing structure, increases to reimbursement rates. So states, I think, really have an incentive to be thoughtful and really craft equitable, sustainable, and inclusive programs for Medicaid coverage for doula care from the start. I also want to really encourage legislators, doulas, policy advocates, and others who are implementing Medicaid coverage for doula care. Really important to make sure that at every step in the process, community-based doula groups and doula groups that are already serving low-income Medicaid enrollees and groups that are led by Black or BIPOC doula leaders of color are front and center, not just in kind of providing input, but also sort of really equal partners in the implementation. I think it's just so important. And then lastly, I think Paula referenced this as well. You know, as firm as my faith is in the power of doulas to positively impact the lives of their clients, you know, we also know that at the end, we can't put it all on their backs, right? So doulas can certainly help mitigate the impacts of racism on their clients of color by advocating for them in the face of systemic racism. But in the end, that systemic racism is still going to be there, harming other people. So really the solution to the underlying racism that plagues America's maternal healthcare system can't simply be throwing doulas at the problem. So as we do this work, we have to remember this, and remembering it, continue to work in other ways to seek out and eradicate racism in all its forms. And then just want to skip to the last slide, which has my email address there. It's just Chen, CHEN @healthlaw.org. So again, if you'd like to be added to the listserv that I mentioned, that I maintain around doula Medicaid coverage, please just send me an email. And thank you so much.
All right, thank you, Amy, Grace, Paula. So first off, a comment. And this is from Ray Van Nolan. I hope I pronounced the name correctly. Now that Oregon will be increasing the doula rate from $350 to $1,500, there's a pretty big increase of doula engagement and client usage. So good news there, obviously. And this next question is for the group. What's a thriving wage offered under the doula Medicaid program?
I can go first, and I'll defer, you know, to Amy, just given her, you know, national knowledge of what wages are being offered for Medicaid reimbursement. I think what we need to consider too is that, you know, doulas under these Medicaid schemes may, you know, they may have 2 prenatal visits and 2 postpartum visits, as well as attending the birth, which can take, you know, however long nature deems the birth to take. So that really depends. And if you want to, you know, a lot of these Medicaid reimbursement programs pay doulas in a lump sum. So it's hard to determine like what an hourly wage would be, but we have to consider those prenatal and postpartum appointments, as well as like being on call for births. And, you know, trying to manage that, as well as being, there for, you know, 13 to 36 hours for the labor. So I think that those are considerations that need to be taken as well. And I know that, you know, Oregon and Minnesota started off pretty low in their reimbursement rates. And we heard from individual doulas that like about 1,500 is like a better number than what they started at. It's like you need to take into consideration the full scope of what they do, and then what they do when they're not directly working with their clients either, like all the things that they do to prepare to set those clients up with additional services as well.
All right, thank you. Good answer.
If Amy, do you have anything else to say? I have like one quick just thing to add before we move on. I think the other thing to think about too, like Grace said, they have a wide array of scope of services, but the state Medicaid policy will also set scope of practice. And so, you know, depending on, to some extent, so they will say, oh, we're paying for prenatal, postpartum, and the birth, or we're also paying for these additional things. And so that can look different per state, depending on what the state has said, the types of services that they will pay for a doula to do. And I think also just, this is probably obvious, but it needs to be a livable wage where they live, right? Wherever they are, which is very different in different parts of the country. So that's where sometimes the reimbursement rates can look different, as a little bit different as well. Although I think there's a baseline number that needs to be met to some extent.
This is Amy. You know, another thing that I would mention, I think, is Grace sort of mentioned this, that kind of I think a lot of people maybe who aren't familiar with the services of a doula sort of don't understand how, you know, kind of the time that's involved and sort of the number of hours that doulas spend with each patient. So for example, in California, we sort of did interviews with a bunch of doula pilot programs that were taking place in the state. And some of the pilots actually were being funded by Medicaid managed care plans. And I know one of the pilots did some really good tracking of the time that doulas spent. And I think on average, they found that each doula spent an average of 75 hours with, you know, sort of with their client, or sort of like prepping for training their client. that was sort of like for just like a single client or single family that they were supporting. So it's really just a tremendous amount of time. And I do want to just lift up again the Advancing Birth Justice report, because in that report, there's actually a really great chart that sort of shows this is the average amount of time that an OB spends with a pregnant person. This is the average amount of time that a doula spends with a pregnant person. And then additionally thinking about, I have 3 kids. I had OBs and doulas at all 3 of my births. OB was great. Those appointments were maybe, 15 minutes. Doula was there for like 1.5 hours to 2-hour appointments. Similarly, my OB, love my OB. My OB had like dozens of other patients the same month that sort of in the months that I was seeing her. My doula only had 1 other client who was due the month that I was due, and that's just because sort of the realities of how many clients doulas are just able to take and sort of be able to provide that support for.
Okay, guess we'll move on to the next question now. But that's a really interesting conversation y'all have going on. That said, are you seeing what are you seeing in terms of the tension around reimbursement for midwives? When states are reimbursing at $1,500, that is a rate that is very similar to them.
Yeah, I can speak really quickly from our perspective. We heard that anecdotally in our interviews, and that's something that we hope to investigate further in the future through our work, as look at the experience of midwives as well.
And I don't know. I think I don't know the reimbursement. I think that's also tends to be fairly state-based. And so I don't know what that looks like state to state. So like Rhode Island has $1,500, and maybe that is what their reimbursement is for midwives too. I think it's a concern in terms of how we are, but I also think there's some opportunity. This is not necessarily regarding reimbursements, but there's opportunity with the attention towards doulas to really use that platform to look at the whole perinatal team. When we're thinking about care that we know that promotes outcomes, but then thinking about the workforce that's really needed to be a part of that care, midwives are a really important part of that. And so how are we also, bringing that into this conversation when we're thinking about policy overall to support better outcomes?
I think that's correct. And I know I feel like I'm like a, what's it called, like a broken record here, but I put in the answer to that chat, the link to that Advancing Birth Justice report that I keep bringing up, because there is a section of that report that specifically sort of says like why physician and midwife payments, sort of like why doula payments should not be benchmarked to physician and midwife payments. So I'm just going to let you all read that. I feel like the report will do a much better job than me explaining that. But I also will say that I think in our conversations, exactly as Paula said, I think sort of increasing access to doulas and midwives and birth centers, sort of, all these types of care, I think makes sense. And I don't think, having a sustainable reimbursement rate for doulas does not mean that we cannot also push for a sustainable reimbursement rate for midwives.
All right, thank you. Next question. Even though each state is different, I think it would be really beneficial to start together a national group to support best practices as Medicaid rolls out and to support the voices of CBOs over just a couple big national voices per se. Are you aware of any efforts to start gathering such a national group?
Amy, you had sent, I'm just going to blank on the name of the report that you just sent out. I had pulled it up. This isn't necessarily a group, but it is, moving in that right direction. Mm-hmm. The Center for Healthcare Strategies just sent out a big report around covering doula services under Medicaid. And they did a number of interviews with both doulas and community-based organizations, as well as Medicaid providers, to talk about all the considerations as you're thinking through policy. I thought it was actually really comprehensive and well done. We can include that information in the resources with this. I would say in terms of the collective, a lot of states are building state level advisory boards. And I think Amy from the health law program is really well connected to a lot of those groups that are getting developed just through the support that you guys are providing.
And thanks, Paula. And I also wanted to mention, I think that was a question, was that a question from Rabin? Rabin, I would love to see something like this. I think, AnHelp would love to be part of something like this as well. I think the question is sort of who the partners would be and kind of where the funding would come from. So would love to maybe, I can, I have Raven's contact information, so I can connect. And maybe we can sort of have some of those discussions. I also wanted to mention that the Institute for Medicaid Innovation is doing a learning series in this coming year around sort of like expanding access to doula care. I can try to find, I'm kind of looking for it online, but I can share that out. So that is one way that I think people are hoping to connect. It'll be a year-long series. I think it starts in January. Oh, did they already? No, sorry. They already had their first session in earlier this month, and I think it'll continue through 2023. So I can, I'll try to share that in the Q&A or in the chat, and I think that can be another way to sort of engage with doulas and advocates in other states.
Yes, and as I mentioned to you earlier, we can certainly share resources around this webinar on our website for everyone after the event. With that said, we are getting close to the end here, and unfortunately, we're just not going to be able to get to all the questions. So with that in mind, do y'all have any closing thoughts? Like should we really take away from this conversation and presentation?
I think that this, the landscape is changing and there's a lot of attention being drawn to doulas, but I do think centering the conversation with doulas themselves is really important as we continue to discuss options for Medicaid reimbursement, private insurance reimbursement. I think there was a tendency, what we heard in our interviews, is that states, Oregon and Minnesota went first in expanding coverage for Medicaid for doula services, and states were just kind of like, oh, that's neat, and copy and pasted without really thinking about their state and what their specific Medicaid populations need or the doulas working in their state. So I think just centering doulas in that conversation and leveraging the experience of community-based doulas specifically, who already work with these communities as well is really important.
I think two things. One, I think just piggybacking off of what Grace said, I think a lot of the policies just end up being very outcomes focused. We all want to address perinatal inequities, but then kind of forget about all of the pieces that need to happen. And like I said earlier, the workforce that needs to be a part of this, and how are we supporting the workforce? So really taking a step back and thinking through, if we don't have this workforce and this workforce that's being supported and has, with well-being, et cetera, we aren't going to be able to move forward. But I think the other piece of that too is, and got brought up a little bit, around educating around doula's role and part, because I think as there's more advocacy to have doulas be a part of the perinatal care process, then we really need to make sure that they're also not experiencing trauma and discrimination in those settings, which I think is happening a lot still. And so how are we working with other providers and other parts of the workforce to really promote collaboration and have everybody be able to kind of understand and, be able to own their parts, but also be comfortable with, working with each other in those settings. So I think that would be another point that I bring up.
Yeah, thank you both, and thank you again for having me today. I wanted to share, I think I didn't mention this earlier, but our work at the National Health Law Program has always been focused on full spectrum doula care. So in other words, doula care for all the ways in which a pregnancy can end, including abortion, miscarriage, and stillbirth. We've always done this because we really understand that our reproductive lives do not take place in a vacuum. So you can't really separate birth justice from reproductive justice, just as you can't separate autonomy and decision-making about our bodies when it comes to pregnancy from autonomy and decision-making about our bodies when it comes to other areas of reproductive health, including abortion, contraception, and family planning. We also already know, since we're talking about maternal mortality, that states that put in place abortion bans have higher rates of maternal mortality, morbidity, and near misses. So I guess in closing, I would just want to say that I really think that our broader fights for reproductive access and abortion following the Dobbs v. Jackson Women's Health Organization Supreme Court case in June really have to go hand in hand with this conversation around doula access and birth justice as well.
All right, thank you. This was a very interesting conversation. Thank you, Paula, Grace, Amy. It's great to have you. Have a good afternoon. Goodbye.